Hi everybody, I'm Dr. Deeksha Pandey and you are watching Urogynecology for Beginners. So some time ago we had started a series on instrumentation for various surgical procedures, but then in between I think we forgot to do more. We have already demonstrated 3 procedures earlier. One was TOT or tension-free vaginal tape by obturator approach, one was vaginal hysterectomy, and 1 hour much liked video which is on sacrospinous ligament fixation. So these three procedures we have demonstrated in Mia model and discussed the instruments and various steps and suture material what is used for that. And today, in continuing the same series, we are going to demonstrate the procedure of retropubic tape today for stress urinary incontinence. So before we start, let me introduce, you already know them, let me have the pleasure to introduce my fellows to you who will be presenting the surgical procedure in a dummy today. On my right side is Dr. Suvrati Bansal and on my left is Dr. Dheera Samdariya. And my job is to only ask questions. They will be showing you and answering all questions which are asked. So feel free if you also have, despite this intense discussion which we are going to do in next 10 minutes or so. So before we start the procedure, let me ask you one thing,
Yes,
that for when we choose for which patient, okay, we have 2 approaches of
Yes,
tension-free vaginal tape for patients who are having stress urinary incontinence. Now, suppose there is a lady who
Yes,
had SUI,
Yes,
demonstrable SUI, she is ready to undergo surgical procedure.
Yes, ma'am.
Now it is up to you. Patient cannot decide. You
Yes,
have
ma'am.
to choose whether you want to put obturator tape or a retropubic tape.
Okay, ma'am.
How do you decide which patients specific 1, 2, 3 are for retropubic approach?
Okay, ma'am. Definite indications for retropubic tape. One will be severe SUI. So severe SUI, we will ask them in the OPD if on change of position or posture if they are leaking, we'll get to know. And even on demonstrating, there will be a parabola. These patients are candidates for retropubic tape. Another thing, ma'am, obesity. Patients who are obese, we would go with this. And ma'am, thirdly, patients who had a previous surgery which had failed. So we'll go in for this. If it was TV, usually it is TVT-O.
So these are the 3 important indications
Yes, ma'am.
that we have to do. But let me tell you one more thing. If you review the guidelines
Yes, ma'am.
of the entire world and the society or people who have done both the procedures, the current recommendations as it stands in 2023, it says that all patients of SUI
should TVT-R
should
is
undergo
superior.
retropubic tape.
Yes, ma'am.
There are many advantages of doing retropubic tape.
Yes, ma'am.
Dheera, would you like to tell what are the advantages and what are the scares of doing retropubic tape?
Ma'am, in a retropubic tape, the complications are more so intraoperative, whereas in a obturator tape, it is seen post the surgery, ma'am.
So usually complications, if we see, these are intraoperative complications.
Yes,
and what most important complication?
Ma'am, bladder perforation.
Bladder perforation. Okay, that also the statistics is like that for 9 to 10 bladders will have perforation if you do 1,000
cases. Yes.
Okay. So not very common, but it is one of the possibilities that because you are so close to the bladder, you might, if you don't take proper precautions, you might perforate the bladder.
Yes,
okay, that is one thing. But efficacy-wise,
efficacy-wise, a retropubic tape is definitely better than the obturator tape because, as you mentioned, ma'am, when you put a retropubic tape, 3/8 of a circle of the urethra is covered, whereas in an obturator tape, 1/8 of a circle is covered.
Okay. So retropubic tape, I will repeat it, is the procedure of choice for all kinds of stress urinary incontinence if you are planning for surgical management. Okay.
Yes.
But one more problem if you want, like when we were discussing retropubic tape, you said that bladder perforation rate is high. So how we can reduce this problem? How can we reduce the problem?
Ma'am, so
procedure is okay,
yes.
But after the procedure, can you do something to detect early so that it can be fixed?
Detect bladder perforation early?
Yes. Every procedure we do.
Yes,
that is a must.
Yes, ma'am. Ma'am, post surgery we will do a cystoscopy.
Very good. So after putting the tapes in place, before pulling them out, you have to do a cystoscopy to see what is the placement of the tapes.
Yes, ma'am.
And if the tapes are inside the bladder, how much scared are you? You are sad,
Yes.
but are you very scared?
No,
No,
ma'am.
because what is the simple treatment?
You just have to
Just prolonged
remove it.
catheterization.
No, you
Yeah.
have to pull out the
Yeah,
tape,
yeah.
Yes.
place it again.
Yes,
Same
ma'am.
tape can be placed little more laterally.
Yes, ma'am.
Do cystoscopy again. Check that. Hope it is not perforated again. So you don't have to do anything great. You have to do for 5 to 7 days. You keep the catheter, though even 3 days catheterization is more than enough. So you feel bad if you have perforated, but it is not such a big complication that you should not do such a good procedure, just worrying about one small little thing. But the problem happens when you forget to see it.
Yes, ma'am.
When you have perforated
Yes,
the
ma'am.
bladder, that mesh tissue is going inside the bladder, remaining there. That will cause more problems. What kind of problems it can cause?
If the mesh tissue is inside the
Mesh is inside the bladder tissue,
yes, ma'am.
and you have forgotten, you have not
Right.
seen, you have sent the patient home.
Hmm.
What problems patient can present with that?
Ma'am, infection.
Yes,
Yeah.
so patient can have, there is a foreign body
Yes,
continuously
yeah.
there. It can irritate the bladder, it
Yes,
can
ma'am.
cause cystitis, recurrent bladder
Recurrent.
infection.
Yes, ma'am.
What other thing?
Ma'am, the mesh can also extrude.
It's already extruded in
In a
bladder.
way, yeah. But
Ah.
exposure, can that happen? I don't know.
No, so it cannot. It is
Yeah.
already extruded in the bladder.
Okay.
Okay. So what else can happen? That it can form a nidus for stone formation.
Okay.
Oh, okay.
Okay. So chronic infections and bladder irritation, patient might keep on complaining of urgency because there is a foreign body continuously inflaming and irritating the bladder, and it can be a nidus for stone formation. Okay. So all these problems but can be sorted out by spending 1 extra minute of doing a cystoscopy. And if you are seeing the mesh, there is nothing great. You feel sad, that's okay, but you just take out the needle from its place. Go this time little more laterally, and after placing it, again do a cystoscopy to check that, hoping that this time at least it would have been normal. Yes. Okay. So with this information, so we were talking about guidelines. So one more thing I would like to, so when the entire world is recommending that obturator tape is not the treatment of choice, rather we should be offering patient retropubic approach as of today.
Yes, ma'am.
So why are we not using it?
Ma'am, first is the economic constraint.
Yes.
With retropubic tape, it is at least 10 times more expensive than the obturator tape.
Definitely. So cost is the major factor.
Yes, ma'am.
And maybe all other things are secondary. In country like ours, we don't have many sellers or many
Manufacturers.
manufacturers of this kind of. We don't have an Indian manufacturer. We have to import
Import it,
tapes
yes,
from
ma'am.
Germany or other countries, other European countries to use that, which actually in turn increases the cost even more. So while tension-free obturator tape can be done within, the tape cost is only 5,000.
Yes, ma'am.
Here the set in bill set is around 50,000.
50,000, yes, ma'am.
Okay, so money is definitely a concern, but I feel if all of us start using this tape, many of us, then it will put a pressure on the companies, manufacturing companies, and it is a very simple system
ma'am.
to develop. And if people start developing, maybe in years to follow, we might be able to use it much more and benefit our women much more as compared to today. So with this background information, let's move on to the procedure. So procedure, Dheera is sitting next to the model, so I hope she is going to demonstrate in the model. So all other questions will come to
Yes, ma'am. Yes,
Okay. So starting after consent, when the patient is in OT, what position you want to put the patient in?
Ma'am, we put the patient in lithotomy
Lithotomy
position.
position.
After that, yes.
What anesthesia is the anesthesia of
Ma'am,
choice?
spinal anesthesia.
Yeah, we always do it under spinal anesthesia until and unless it is with some other procedure. Like there are some cases where we are doing it with TLH and TVT-R. So obviously the patient is under GA, but
If
we
this is
prefer
happening isolated,
spinal.
spinal.
Do you think so? That
Yes,
is
ma'am.
there any significance, any advantage of giving spinal anesthesia
Yes, ma'am. The advantage of giving spinal anesthesia is
for
that
this particular? Anyway, we all know
Yeah.
that spinal is much better than GA for
yes,
all.
ma'am.
For for this particular case or for SUI surgeries,
Yes, ma'am.
I'm giving you a hint,
Yes,
is
ma'am.
spinal better?
Yes, ma'am, it is better. Patient is relaxed and we are able to demonstrate SUI prior to performing the surgery. Because a lot of times we can't in the OPD, so to have a solid diagnosis, we can do it.
That is for confirmation, but
Yes, ma'am.
according to me, if you ask me, in your practice, you must follow that whenever you are planning, when you have posted the patient, you should have demonstrated before giving the
Yes,
anesthesia.
ma'am. Yes,
okay.
ma'am.
So you can confirm your diagnosis, you can check the severity once again, but still never take a patient to OT if you have not demonstrated
Yes,
the
ma'am.
patient having SUI. The confirmed plan you don't
Yes,
give.
ma'am.
Maybe you are doing with VH, you can always give her an option.
Yes.
Patient, you are saying that you have, but we are not finding it. We'll check once more in OT.
Yes,
But
ma'am.
just for the sake of TVT-R, you must not take up the patient until and unless you are able to demonstrate it in
Yes,
OPD.
Yes,
Okay, that is one point. But I feel you want to add on something, Dheera. I feel you want to say something.
No, ma'am, that's so. When the patient is, we can ask the patient to cough and we can
Is
demonstrate.
it more important for demonstration? No, demonstration you should have done
Right.
before.
Yeah.
So for what spinal anesthesia is helpful? Not for demonstration, for
Ma'am, when we are checking
After
later,
adjusting the tape.
adjusting the tape, when we are
Okay.
checking later,
it is very, very important for tape adjustment.
Yes, ma'am.
Because how much the tape, it is a simple rule for any kind of tape what you are putting, that it should not be too tight.
Yeah,
We
undercorrect.
say that patient should not be dry after putting a tape in
Yes.
OT.
Yes.
Yes, ma'am.
The dictum is that she should leak at
2 to
least
3 drops.
2 to 3 drops of urine when you tell her to cough. Okay. So if patient is not able to do that, that means your tape is tight and you must loosen it. And why is it so? Why we take that to? Why we want to keep little incontinence intact?
Ma'am, because
What is the rationale behind it?
Ma'am, once the spinal anesthesia wears off, the muscles will become tighter and she will be able to hold it better.
This is a very, very important learning point which all of us should always remember, that patient should not be totally dry immediately after taping her. Okay. So I think we have discussed so many things. Meanwhile, we'll keep on repeating what
Yes.
important thing comes in. And Dheera has told that patient is under spinal anesthesia. She is in lithotomy position, painted and draped. You are standing on the vaginal side of the patient. Now what do you do?
ma'am, first I'll insert a sim speculum and I'll first demonstrate the SUI if it's possible.
I want to tell one very small thing it is, but very practical thing,
Yes,
which I learned after doing it, that usually as vagina surgeons, we are used to using a whole towel.
okay.
One
Yes,
whole
ma'am.
towel we put usually, but for retropubic tape, you should not put whole towel because the hole is never enough.
Yeah.
Yes.
Here our approach area is this area also, suprapubic area. So we have to expose at least from this part till this part, and the holes usually, our OT especially, are very small size, which can expose only vulvovaginal area. And then sometimes when I started doing tape a few years ago, I had to cut the whole towels because the exposure was not enough. So if you want, the draping style can be changed a little bit. You can put one towel above,
And
one drape below, and on the sides are
The leg
leggings
sleeves.
and
Yes.
leg sleeves are there. So you can do some adjustment, but keep that in mind so that unnecessary
The
every time you
exposure is
don't have to
adequate.
cut the
Yes.
whole towel. Okay. After that,
First we'll catheterize the bladder and then we'll put 200 ml normal saline into the bladder and ask the patient to cough to demonstrate the SUI. Then we'll drain the bladder again. Ma'am, we'll insert the sim speculum and we'll hold the...
so you do it. How
Yes,
many
ma'am.
TVT-Rs you have done, Dheera?
Ma'am, 10.
10 you would have done
Yes.
independently.
Yes, ma'am, independently.
And you too.
20.
Okay.
So enough number of TVT-Rs. So you say that I do it like this.
Yes, ma'am.
So Dheera, would you start demonstrating
Yes,
how
ma'am.
do you do a TVT-R
Yes.
procedure step by step?
Ma'am, I'll insert a sim speculum. Ma'am, may I stand?
Yeah, sure.
I'm going to insert a sim speculum. I will infiltrate the mid-urethral part of the urethra. That is the middle 1/3, ma'am. We would hold it with the alleys. So we hold the middle 1/3 of the urethra with two alleys clamps. I will infiltrate this part.
And the length, if I may ask you, what is the length of that middle part of the
1
urethra?
centimeter.
1 centimeter.
Yes. If we take the urethra as 3 centimeters, divided into 3 parts, and the middle 1/3.
This is an easy calculation because in practicality, whenever we are trying 1 centimeter, it is not always, it becomes 1.25.
Yes, ma'am.
But if you think that you will give 1.25, it will definitely become
Become
1.5 or
1.5.
more. So we think that will give 1.
1
Yes,
centimeters. Yes.
Ma'am, I will infiltrate the middle 1/3 with diluted adrenaline as we take 1 ampule in 200 ml normal saline. We generally infiltrate 30 ml, one in the middle, and
10
laterally
10
on
ml?
10 ml on either side. Yes. I will take the knife or the monopolar cautery and put an incision in the between the Alice clamps.
Vertical incision.
Vertical
So
incision.
important point here that in this particular procedure, you don't have to open a 23 number blade.
Yes.
11 number blade is good enough if you have one, because the same you will use for the vaginal incision and same you can use for the stab incision on the suprapubic area.
Yes.
So this is the blade with 11 number blade with scalpel.
Yes. Ma'am, with a tissue cutting scissors.
You will hold it and
Yes.
show how you straight line
Yes.
you draw. Yes. This is the incision given.
Once the incision is given, I will release the Alice from here and put it on either side. For demonstration, I'll put it on one side, ma'am.
Okay.
I will take a tissue cutting scissors and I will dissect the area. Just minimal dissection is sufficient in a retropubic tape.
So I call it just one pulp of a finger,
Finger.
index finger is enough to be dissected.
Yes.
But what should be the direction of that dissection?
It should be towards the ipsilateral shoulder.
Shoulder of the patient, yes.
So we will keep our index finger behind and I will just dissect it lightly.
Alongside the vagina.
Alongside the vagina, yes ma'am. Alongside the vagina towards the ipsilateral shoulder. Once I've dissected this side, I will take the Alice clamp on the other side of the incision and similarly dissect this side.
So both sides, one pulp of finger tunnel you have created.
Yes ma'am.
And when you do that, you get a feel that you are perforating the fascia.
Yes ma'am.
Okay. After that, what
After
do you
this, I will give the stab incision over the suprapubic region, and our point will be to place a finger on the pubic symphysis, and it will be 1 finger breadth lateral and above the pubic symphysis.
So how you do it? From
Yes.
midline you keep 3 fingers there,
Yes.
and on the edge of one
Each-
finger.
Yes,
this
just
side.
above the pubic symphysis
Mhm.
and just lateral. There'll be 1 stab incision here and another stab incision on this side.
Very good. After that,
Ma'am, after that we would
very good. Remove
yes.
the catheter first. You have
yes.
put Foley's catheter before you told.
Yes.
So you have to remove
Remove
the
the
Foley's
Foley's
catheter and empty the bladder.
Yes,
See
ma'am.
that the bladder is entirely empty, because you only told there is very high risk of bladder perforation if we do not take proper precautions. So one of the first precaution is
Empty
to
it out.
keep the bladder collapsed.
Yes, ma'am. So once after we remove the catheter, I'll ask my assistant
Mhm.
to insert
Okay,
the.
I'll be your
Yes.
assistant. Okay.
Ma'am, we can to deflect the bladder to the opposite side of our where we enter the tape.
Yeah.
So if I'm inserting the tape on the right side, we will insert the. Yes.
It's okay.
We
For
can
the sake-
either use a bowel pusher or a sound, and we will deflect the bladder towards the opposite side.
So the this rod, whichever instrument you are using, that should not perforate the bladder. You
Yes,
should
ma'am.
not be
It
perforated.
should just
you
be
have
lightly.
to be gentle.
Yes.
And then you come across the. You should be parallel to the thigh.
Right.
Okay.
Yes. ma'am.
Okay, I'll hold it for you.
And this is the retropubic system, where this is the needle, and this is the mesh. We've used the ribbon as the mesh here. We insert it.
So this plastic sheath is very important, because that's why it makes it so good that even if this you have perforated, this is so smooth, the edges are smooth. If you take something rough, if you put the mesh directly, it will injure the bladder much more than the smooth thing.
Yes. ma'am.
Okay, so if you have just put the sleeve and it is blue in color, can nicely be seen when you are doing cystoscopy, and you can just slide off this needle,
Right.
your
Yes,
tape
ma'am.
will come out. So you are actually not damaging, you're just damaging maybe 2 to 3 millimeters
Millimeters.
of bladder accidentally, if any. So it is no injury.
Yes,
It is like a suprapubic catheterization.
Yes, ma'am.
we do.
So once the bladder is deflected towards the opposite side, at the point where I've dissected in the paraurethral region, I'll just go 1 centimeter in, and once I feel the giveaway that
And
I've
direction,
entered the
once you
fascia.
enter, direction is towards the
ipsilateral shoulder.
ipsilateral
shoulder. Yes, ma'am. Once I enter, it's towards the ipsilateral shoulder. Once I know I've pierced the fascia, I will make it vertical, drop it down. If needed, I can remove the speculum. And I will go upward and bring it out from my stab incision.
Very good. And all the time you should feel that you are going parallel to the pubic symphysis. You're just next to pubic symphysis. Don't go into the bone also,
Yes,
because
ma'am.
if you go into the bone, you will be injuring the periosteum.
Periosteum,
And
yes.
it is very, very painful
Yes, ma'am.
post-operatively.
Periosteum.
You just have to stay very close to the symphysis pubis.
Yes.
And you should not go. This procedure is very good. Okay, we'll discuss what are the problems and complications can
Yes,
have
ma'am.
later. Now we are not perforating this model because we have only one. Actually, these can be used for practice models, but we own only one, so we cannot
Yes,
afford to. So this needle will come from the stab
from my
incision.
stab
here.
incision. So once it's out from the stab incision, I
What
pull
do you
out
do?
the needle.
With an
And then
artery.
we hold the edge with the artery. Once this is done, it's coming to the next side. We once again will deflect the bladder to the opposite side this time.
And in the similar fashion, the needle will come out. Now I
Yes,
have an idea. What we can do, we can dismantle this a little bit, remove this abdominal layer. I think that will be easy for us to understand.
Okay.
As Dheera has removed the abdominal covering here, so that the demonstration becomes more clear.
Yes.
So can you show anatomically how
Yes.
this needle will be finally placed?
And for demonstration purposes, actually our needle would go from here, but since we don't want to pierce it, ma'am, for demonstration purpose, I'll go by the side. And it comes just next, just above the pubic symphysis, very close and lateral.
And you can see the bladder is
Bladder.
here.
Yes.
And once you put, where is your deflector? Once you put, you try to understand it, that once the deflector is there, it should be deflecting. This bladder is made up of little tough tissue, but so it gets deflected like this. Okay. So bladder, it is, though the needle is very close to the bladder. Can you see this? Can you show this one?
So this is the bladder, and we are very close. We're just lateral to it. And our needle comes out very close to the pubic symphysis.
This is, so I'll hold this needle, you remove this one. And put it from the other side.
We will again fix it. We will again fix it and come out through the other side. Through the space that we have dissected. Once again, for demonstration purposes, I'll be going by the side. And we come, hugging the pubic symphysis and above without perforating the bladder. Once again, we hold it with the artery forceps and bring the needle out. Yes.
After this, what do we do so?
Ma'am, after this, first now we are going to do a cystoscopy
Very
and
good.
see the lateral walls if there is any kind of perforation or
Or
anything.
breach in mucosa.
Yes, ma'am.
And then if we see, if by chance there is perforation, there will be two signs. One, as soon as you put the scope, there will be let the bladder distend, and then there might be little bleeding. If streak of blood is coming, that means you have injured somewhere.
Perforated.
Either while going into the urethra while putting, you have not been careful, you have injured that,
Yes.
or somewhere perf is there in the
Yes.
bladder. The second for sure sign will be that you will see
See
that
the blue.
blue shadow
Yes,
or
ma'am.
blue tape shining blue tape from one of the sides. In that case, you just have to remember that you don't panic there, just remove it, put it little laterally, and keep the catheter in C2 for maybe a few more days or a week to be on the safer side. It will heal by itself. Now we'll discuss a little bit about anatomy.
Yes, ma'am.
So what tape we said is a retropubic tape. Okay, it is, you can see that this is the pubic symphysis.
Yes,
It
ma'am.
is hugging the urethra.
Yes,
ma'am.
And we have not perforated, we have not touched the urethra and the bladder. We have
Yes,
just
ma'am.
gone through the vagina into the retropubic space
Yeah.
and come out through the abdominal wall.
Yes, ma'am.
Yes,
Okay,
ma'am.
it is not even touching directly the bladder or the
Yeah,
urethra.
right.
It's just providing the support
Yes,
there.
ma'am.
Okay. Now this space is a wonderful magical space.
Yes, ma'am.
Why it is magical? Because
It's an
it is
avascular space,
totally avascular space, but you have to remember it is a safe space.
but it's a small space.
It is a small
Small
space.
space.
It is a very narrow margin there.
Yes, ma'am.
If you go little bit medially,
Yes, ma'am.
what will be the problem? You will injure
Urethra.
Bladder and
urethra.
urethra. Yes, ma'am.
Bladder.
If you
Yes.
go little posteriorly, what will be the problem? You injure the bladder.
Bladder.
Yes, ma'am.
Okay. If you go little laterally this side,
Yes, ma'am.
what is the problem?
Iliac.
Iliac
Vessels.
vessels,
Yes,
external iliac. Just at the when the external iliac vessel becomes the femoral artery,
Yes,
Yes.
ma'am.
they are just crossing here. You can see in this distance only is hardly this much.
Yes,
Yes.
ma'am.
If your angulation is not correct, if you have, rather than just tilting it towards the ipsilateral
Yeah.
shoulder, if you do
Too
little
laterally.
more over enthusiastically,
Yes,
you
ma'am.
are going to puncture
Puncture the
that
vessels.
vessel.
Yes,
Yes.
ma'am.
And over and above this also, to
Aberrant
complicate
obturator.
our problems, there can be at times some aberrant
Aberrant
vessels
obturator
which are
vessels.
coming from the obturator artery,
Arteries.
Mm.
which might get injured.
Yes,
That you might not have a lot of control because you don't know where the arteries are running.
Right.
But if we remain in the narrow space, in that 3 centimeter or 2.5 centimeter space,
Yes.
the likelihood of complications are much, much less.
Lesser.
So it is a very effective procedure. It is a very safe procedure. This is the needle placement. So once it is done, and one more thing, it is an avascular space.
Yes,
it is a
ma'am.
narrow
Limited space.
Yes, ma'am.
space, and it has one more quality.
Mm.
It is an extraperitoneal
Yes, ma'am.
space.
Yes,
What
ma'am.
is the advantage of extraperitoneal?
Ma'am, we are not entering the peritoneum, so
Mm.
we are not injuring any viscous.
So that is okay
Mm.
if you are careful, because peritoneum is not like bone
Yeah,
which
yeah.
will hold.
But
If
yes,
you
ma'am.
remain in
ideally,
this
we are
space,
not entering.
not entering the viscous. More important than this is that you are not causing any kind of, you are not taken from vagina any infection to the
Yeah, yeah.
peritoneum. That
Yes,
is more
ma'am.
important.
Okay.
Okay.
Yes, ma'am.
If you want to injure, you can injure anything, but if you remain in that place, you are not entering. All the advantage of not entering the peritoneum is that peritoneum is a Pandora's box. If little infection goes inside, it will
Yes,
spread
ma'am.
everywhere. So you are preventing that. One more advantage, even if you have done a perforation as we discussed and you
Yes,
have
ma'am.
rectified it, then also with that hole, if urine leaks, it will not enter the peritoneum.
Peritoneum.
Oh, yes,
It will
ma'am.
remain in the extraperitoneal space and get
Extraperitoneal
absorbed from there.
Yes.
Okay, so that is
Mm.
another added advantage of
Advantage.
this retropubic space.
Yes.
So with all these advantages you have placed, and luckily we think that, have you done any bladder perforation till now?
No,
Not
ma'am.
yet, ma'am.
Very
Not
good.
us.
I have done one. I have done two rather. Okay, but it's okay.
Yes, ma'am.
So when the number increases, complications. So one of my very favorite saying
My
is,
teacher was better.
Yes.
but I always say one thing, that complications, if somebody says, and not for you, you are the beginners,
Yeah.
if you say that I have not done any complication in my life, there are
And
only
you
two
only done
reasons.
Yes,
little.
ma'am.
One is that either you are lying, that you
Yeah.
never had a complication, and second thing, that maybe you have never gone to OT, never done a case, so you never had a complication. Okay, so but I hope you will never have a complication, but we should be ready for it.
Yes,
Yes,
ma'am.
And it can happen with anybody. Okay. After that, luckily, in this patient, bladder intact, everything is perfectly fine, bleeding is within normal limit, and you have checked everything fine. Now, what do you do, Dheera, after this?
Ma'am, now we would adjust
I'll
the
put.
tape.
Should I put the speculum?
Yes.
So will you hold this?
Yes, ma'am.
speculum?
I'll hold it once.
Ma'am, after the cystoscopy is done, we will again catheterize the bladder,
Mhm.
and now we will adjust the tape. So we will ask our assistant to pull the tape
Mhm.
from both sides together and I will keep my finger here so that the tape does not get too tight.
So this
Finger
is one
or artery?
modification.
Finger or artery.
So
long
this is
artery,
what I
yes.
wanted to say. This is our own modification that many people say that you should put scissors there, okay, to keep it loose.
keep
Some
it like
people, if you read the
Yes.
books, you will see that usually people put a scissors there to create little space around. Many people use an artery forceps on a right angle
Yes,
to
ma'am.
keep it loose. What I have seen over the years, that best thing to adjust is your own finger. You just keep one finger over here and just keep on pulling. It gives perfect tension. I think it is a very good tool. You can just, suppose we have cut
Cut
this.
this, yes, ma'am.
And always you have to,
So with my index finger placed here,
Mhm.
we would pull the tape.
and
And
better
once
to
we
have
near
a
it, yes.
gap of one finger. Anyway, we are not cutting these tapes immediately. We keep them for adjustment for day 2 after surgery. So even if it is little loose now, it's okay. Years we have been following this technique. It has no chance of injury. You get a feel of tightness with your own finger. Now, I think it works very good for at least us.
Yes, ma'am.
Okay.
So once we know that our finger, it is close to our finger,
Mhm.
and we are happy with the tape and how it's placed, we will once again, fill the bladder again with 200 ml normal saline and ask our patient to cough.
Mhm.
And we need to see at least 2 to 3 drops of leak of urine.
Okay, so by chance this patient, because of some reason, because maybe you have done TLH for her or any other surgery for that matter, and patient has been given general anesthesia.
Okay, ma'am.
Patient cannot cough on demand,
Yes, ma'am.
okay, on instruction. So what do you? Do you have a test to do
Yes,
that?
ma'am. Yes, ma'am. So what we'll do is after filling, like she said, we will apply intermittent pressure on the suprapubic region.
Yes.
So the idea is to just increase intermittently the intra-abdominal
Yes, ma'am.
pressure. So we just put a fist and
Yes.
keep this very
Push.
suprapubically and push. Push should not be continuous.
No,
Yes.
And
intermittent.
like civil
Like
maneuver
we
yes,
to
yeah,
emulate
huh?
cough.
Yes,
Yes.
exactly that way. And that also is a good method. In
Yes,
that
ma'am.
also there should be a leak of 2 to 3
Drops.
at the end of the procedure.
Yes.
Don't tighten it more. If suppose you have placed the tape with all your technique
Yes.
and patient is totally dry, you must come and
Loosen it.
Loosen
the
it.
tape.
Yes, ma'am.
After this is done, should I cut the tape here now?
I'm
No,
loosening
ma'am.
it, ma'am.
Okay.
Okay.
Loosen it. After that, what do you do?
Ma'am, we do not cut the tape. We leave it.
We just cut this.
We
ends,
remove the ends. We cut the ends. Here we are removing it.
Yeah, sorry. And group it.
After this, we will
And put it covered
Yes,
with
ma'am,
a
at the
tape.
end,
Waterproof,
yes.
yeah.
Waterproof
bandage. Yes, ma'am.
We fold it and then we cover it with as ma'am said, with a waterproof bandage.
Okay. Then
We will close our incision, anterior vaginal wall incision, with generally with monocryl 30 or monocryl 10 also can be used.
yes. And if you have, suppose you have a long segment of 20 after vaginal hysterectomy, vicral, normal
That also
vicral,
can be used.
that's also is
Oh,
fine.
yes,
Don't
ma'am.
waste suture unnecessary. If you have that, that is also. If you don't have monocryl, don't think that you cannot do this procedure. This set, retropubic set, is more important than any suture material or
Yes.
any other instrument. We can make use of anything. Okay, with this the procedure is done.
Yes.
You
ma'am.
don't have to, it hardly takes 10 minutes, and it's a very beautiful thing to do. And really, that if the system is good
Yes.
and it's easy, you will not get any resistance. It is not like manipulating TVT-O needles. So it is one of my favorite procedures. Okay. After that, you have sent the patient. We'll finish the thing because follow-up is also very important in
Yes.
these cases,
Yes.
because it is a very crucial titration between adequate tightness and looseness.
Yes, ma'am.
Okay, because if it is little tight, patient will go into retention. If it is little loose, patient
Problem
will
is not solved.
She will remain incontinent. So how do you do? Now you have sent the
Yes,
patient back to ward. Suppose
Yeah.
9 o'clock the procedure was done and the patient is sent to post-operative ward.
Yes, ma'am.
Then how do you follow?
Ma'am, so we'll in the ward, what we'll do is
So first 24 hours you don't have to worry. Just
Yeah.
look after
Yes,
pain
ma'am.
of the patient.
Yes,
All
ma'am.
normal orders you follow.
Yes,
Keep an
ma'am.
MP.
And like we'll do the output monitoring, but we'll keep the catheter in situ. One day later, we'll ask the ward nurses to remove the catheter, and they still have to measure each of her voids and then the next day.
So each of the voids measuring that you have started,
Yes, ma'am.
usually I was not into, before you guys came, I was not measuring that much.
Okay.
So I just asked. So I
Yes,
divided into 2 groups. So
Hmm.
first day, for first 24 hours, patient is catheterized and being monitored with whatever
Yes,
normal
ma'am.
post-op orders. After 24 hours, you remove the catheter.
Yes, ma'am.
And for me, for easy understanding,
Hmm.
for one day, it is subjective day, the
Okay.
next day is objective.
Objective,
Okay,
yes,
ma'am,
ma'am.
okay.
Hmm.
So subjective day, I just used to go and ask the patient
Feedback.
if she is feeling, if she is able to urinate properly.
Yes.
If she is having, most importantly, if she is having any voiding difficulty. If patient says that without any difficulty, I am passing urine every 2 to 3 hours, then I am fine with that. And I also used to ask if she is feeling continent.
Yes.
Because
Okay.
some women
Yes,
who
ma'am.
are who were having severe, this state we are using usually for severe
Severe
Yes,
SUI.
ma'am.
So those are the women who even with change of posture used to have problem.
leak. Yes.
So at least if that is gone, they will be able to tell.
Feel better.
Usually on first post-operative day, patient will not dare to cough because they are also worried, they
Little
also
worried,
have
yes.
pain. But if the problem with so much so, which usually we see when we recruit these patients for the retropubic approach, that even with change of posture, they were having this problem.
Yes, ma'am.
So if by chance patient was like that, she will definitely tell that her quality of life has improved. She's not having that kind of leak now. So 2 extremes you have to ask about the leak, about the SUI, and about voiding difficulty.
Yes, ma'am.
You can measure the urine, whatever you want to do. But I am telling you, before you came here, I had never done that. Okay. Day 2 is the objective day.
Yes, ma'am.
What do you assess an objective? Again, 2 things we have
Yes,
to take.
ma'am.
It should not be too tight, it should not be too loose.
Yes, ma'am.
So how do you do it?
Yes, ma'am. So first thing what we do is we'll ask the patient that her bladder should be like she should be wanting to pass urine. When she's at that stage, we are going to take her to the examination room and we will try to demonstrate SUI. We'll roughly assume that much urine must be in the bladder.
So exactly like uniform cough
Yes,
stress
yes,
test.
ma'am. We will
When
try
she
to
gets the
demonstrate.
urge, around 150 to 200 ml of urine is there, and we tell her to demonstrate.
Yes, ma'am. And if she is dry, she is not having any SUI, that means we are good. Then we will ask her to go and pass urine. Once she is done evacuating, we will check her post-void residual urine. And that post-void residual urine, if it is less than 100 ml, she is good to go.
So less than 50, very good.
Very good
Yes.
to go.
50 to 100 acceptable.
Yes,
Yeah,
ma'am.
okay. Because when these patients will come for follow-up, that would have 100 would have come less than 50
Less than
for
50,
sure.
yes, ma'am.
Because initially for a day or 2 patient will have
Inhibition.
little edema, little pain.
Pain.
With that she will not be, but up to 100 is acceptable.
Yes, ma'am.
But more than 100 you should do something.
Yes.
Now let me give you a scenario.
Okay, ma'am.
Patient says that I will give you various scenarios, one by one you have to answer.
Okay.
Now this patient number 1 says that
Yes.
I am able to void properly.
Hmm.
I am able to control urine. There
Okay,
is no SUI,
Hmm.
and she is voiding. So subjective day is perfectly fine on day 1.
Okay.
When you started seeing objective day,
Hmm.
there was no leak on cough, so
Yes,
SUI
ma'am.
has gone. She has
Okay.
become dry.
Hmm.
But when you told her to go and pass urine, and you checked her post-void residual volume,
Hmm.
okay,
Hmm.
it is coming 300 ml.
Hmm.
Okay.
What is the interpretation of this? Do you need to correct it? Why do you need to correct it? Patient is perfectly fine. She's the most happy lady in this world.
Okay.
But 300 ml of post-void residual urine is there.
What we will loosen the tape.
Hmm.
Yes, ma'am, because 300, as you said, is still above our acceptable
Threshold.
limit.
Hmm.
So we will loosen the tape. And
If you don't loosen,
okay, ma'am.
if you just keep it, why we are worried? Patient is fine. She's passing urine. She's holding urine.
Hmm.
Functioning is fine. Why do you want to loosen the tape and make it within 100 ml? That
And
was-
because each time, if the urine keeps getting collected in the bladder, one, it can continue to distend. And if she's not even emptying completely, one, if it over distends, there can be
Those receptors,
yes,
like,
ma'am, the bladder receptors
both
can get
things will happen, ma'am. One thing is if urine is getting collected, there is stasis, chances of infection will
that is
increase.
the only problem.
Okay.
Okay.
Mhm.
Because patient is able to void.
Void.
Yeah.
Okay.
It will never over distend.
Okay.
Okay.
Yes,
It
ma'am.
will
Yeah.
remain little bit residual. urine.
Okay. Yes.
So repeatedly, if residual urine, the dirty urine remains every time, and patient
Right.
is not able
There
to
will be
empty,
infection.
it will lead to recurrent infection,
Infections.
which
Yes,
will be
ma'am.
very difficult for you to treat later. That's why we should do only one straightforward reason.
Yes.
Now, in these cases, you would like to
Loosen
loosen the tape.
Loosen the
tape.
So,
Yes,
so how do you loosen this tape?
Ma'am,
now?
so for loosening the tape, we can use, what we do is we usually use an artery forceps. So we will keep that, we will keep the, ma'am, so we have checked the postvoid residual urine, like you said, it came in 300. So we will place our artery forceps gently within the urethra and
Within the urethra, 4 centimeter inside the
no,
urethra?
no, ma'am. Only up to the level of the mid urethra where our
Yes.
tape is, because that's the, yeah.
If you go more,
No, not at
you
all.
might cause more harm by injuring the internal sphincter.
Yes, ma'am. No, we will only go up to the level of the tape or the mid urethral level, and then we will loosen it simply by pulling it forward like that, very gently.
And keep your finger in the vagina.
Yes, ma'am.
And what you can do, because usually the tape is tight on the sides.
Yeah.
Okay, and here not much of space. Your suture line is also there.
Yes,
so
ma'am.
what I suggest, just
open
this.
it. Yes,
just
ma'am.
open this.
Yes,
so
ma'am.
lateral sides will open up.
Yes,
like that.
and that much is enough loosening.
Yes. Then what else you do? Okay, this is patient is done. Then you repeat post-void residual
Yes, ma'am.
urine. It should have come
Below 100.
Below 100. If it doesn't come, you keep on doing this. If it
Yes,
is
ma'am.
very tight, maybe you are doing your first case and you have really done over enthusiastic. If nothing is working, you may open this incision from the vaginal side and loosen it, but don't send the patient home with lot of residual urine or with voiding difficulties, because if it is difficult today, it will be much more difficult
once
and
she
not
goes back.
treatable
Yes,
later on, because fibrosis, that mesh functions because of fibrosis and like growth of fibroblasts from the mesh. Okay, so it will not work. So take care of that now only. Then the second scenario.
Okay, ma'am.
Now, suppose this patient says that she is still leaking. Okay.
Yes, ma'am.
And when you try to demonstrate objectively, you see leak is less,
But it's there.
but still there.
Okay. So, ma'am, in that case, again, we will do the same thing. If it is present, we are going to ask her to evacuate first. We will check for the postvoid residual urine as well. And then in that, if we see that SUI is still present, we need to tighten it. So we will do that. And again, we will check, because it should not be too tight also.
So one thing again very important, that usually tightening is not a problem with retropubic tape.
Yes, ma'am.
But in obturator case, despite your tightening, as you said, it should not be too tight also.
Yes, ma'am.
You have to have a balance between post-residual and voiding difficulties and
Both.
incontinence.
Yes, ma'am.
So even some cases, this can happen, that if you have put TVT-O or the obturator approach, with optimal tightening, patient is still leaking. Don't tighten it more. Maybe she was the wrong candidate for TVT-O.
TVT-O. Yes, ma'am.
Okay. So maybe you have to think about it. Then you have to, if 50%, 70% she has improved, you tell her physiotherapy, or later date you can think of putting a tape or
TVT-R also.
because this has happened with one of our patients because of financial concerns. We thought we'll give her a chance. She's 90% better now.
Right.
Okay. She had applied for some Ayushman card which didn't come through at the last moment, so we had to do it. These problems might happen, but if you are choosing where you are supposed to give retropubic and you have chosen obturator approach for the patient, always remember to counsel the patient that this is not the most optimal management for the patient. Keep the patient ready, because of financial concerns you are doing this, and it should be fine. Okay. Then any other scenario you can think of. What is the chance of erosion in this patient?
Ma'am, less than 2 to 4%.
Erosion,
actually.
vaginal erosion is very, very less,
rare. Yes,
because vagina in transobturator tape or tension-free vaginal tape obturator approach, it is just lying parallel to the anterior vaginal wall.
Right.
Yes.
Okay. Here it is just this much.
Yes,
Maybe less than a centimeter is coming in contact with vagina. Only in very small part. So vaginal erosion are not common.
Yes, ma'am.
Like in TVT-O, one more complication is groin pain.
Yes.
And groin, like severe neuralgia and erosion from the groin.
Yes.
Do you have this kind of complication here?
No.
That is the benefit of nice abdominal fat, because it sinks inside the fat and it never
and
goes
just
through
heals
the
completely.
vagina and heals very nicely, completely. It will never come up. And last thing, I'll ask you, when you cut the tape, because I think each and every small detail is important.
Yes.
Do you want to tell some technique when you are cutting the tape in OPD or in the ward? Do you need any anesthesia to cut the tape?
No.
Do you need to suture the incision?
No,
ma'am.
It is just a stab.
Yes,
wound,
yes.
Okay.
Yes,
You can just put a handiplast in them. Can you show me? Suppose that's the tape. Can you
Yeah.
give me so?
Yes,
this one?
ma'am. Yes, ma'am.
Suppose this is the tape. Okay. And it is the abdomen. It is coming out of there.
Yeah.
Then how do you do? Take scissors, something in your hand, and show me. What is the procedure? Hold it with your
Yes.
hand.
You will hold the tape.
And
Just
show this
yes.
thing a little bit.
And then
Hold.
this is the abdominal wall.
Yes.
Just slightly press the abdominal wall
Ah.
so that you're seeing a little lower part of the tape.
Yes.
And since
flush
it's yes, you cut it
Flush.
flush.
So when you leave this, it will
Sink.
It
sink
will sink
inside. It will spring inside the abdominal wall, and abdominal wall will heal. This is the trick to cut it. And I think this is what I can remember to tell you about tension-free vaginal tape. If you guys can remember something else which we discussed, or something, maybe one point after doing 10 cases also which you have not learned, did you pick up some point, I don't know, or everything you knew?
And
Oh,
for me,
from-
I think would be the stasis of urine
Yeah,
for
it is
leading to
important.
infection.
Yes. So knew everything. Okay.
Yes.
So I hope all of you understood this is a beautiful, very satisfying procedure to do. And for patients also, they feel suddenly very happy because you are choosing it for patients who have very
Severe
severe
yes.
SUI. There is sudden, within a day, there is improvement in their quality of life. Long-term results are very good. So you send a happy patient home, and whenever they come, they are so happy to see you and visit you in the OPD. And I think let's all of us start doing this procedure more and more so that manufacturer starts making them more and more to be used for our women. Thank you so much.
Thank
Thank
you.
you.